Hi everyone, can everyone hear me? And if you can hear me, can you just put like a yes in the chat box for me, please? Mm, Can everyone hear me?
Yes, your audio is good.
Okay, thank you. Okay, sorry everyone for the delay. We were having some technical difficulties, but thank you everyone for attending our webinar today. On chest feeding, facilitated by Jacob Ingelsman. My name is Brechelle Parker, and I'm the perinatal program coordinator with Healthy Mothers, Healthy Babies Coalition of Georgia. I will be the moderator for the talk today. A bit on what this organization is about. The Healthy Mothers, Healthy Babies Coalition of Georgia, or HMHBGA, has been around since 1973. Our mission is to improve maternal and infant health through advocacy, education, and access to vital resources. We accomplish this mission through advocacy and collaboration with Georgia lawmakers and by serving Georgia communities in several different ways. We are so excited. We are so excited for Jacob to lead our session today. Please familiarize yourself with the chat box, and we will have around 10 minutes in the end to ask all these questions. With that, I will turn it over to Jacob.
Okay, hi. So first, I just want to make sure people can hear me.
Yes, we can hear you.
Okay, good. Okay, cool.
Okay.
So, as they probably mentioned, we were having some technical difficulties.
There we go.
Get things sorted. Okay, so So this is Chestfeeding 101, an overview of lactation concerns for transmasculine and non-binary people. My name is Jacob Engelsman. My pronouns are he, him, and I'm an IBCLC located in Atlanta, Georgia. And I decided to hold this webinar because I feel like a lot of lactation and birth professionals in Facebook groups and different online forums kind of feel like they might be getting left behind by the LGBT community. And there have been changes in language and sometimes what is considered appropriate. Some of these are cultural and some people are viewing as more official. In February this year, there's a hospital system in England and Wales that started encouraging midwives to add the terms chest feeding and birthing parents to their lexicons, and there was a lot of response to that, some of it positive and some of it negative. And one of the points that was made was that nobody was asking the midwives to remove any words from their vocabulary just to add new words. But there was a lot of debate about that. So I just wanted to, this is just like I think of this as like a service that I provide for other cis people who want to learn about these subjects. So, yeah, if we can do next slide. So I'm going to have a few questions during the presentation. Some of them, one of them is a poll and some of them are short answer. I do ask that you keep your answers to just a few words so as not to clog up the chat box. And I can't actually see the chat box because I'm using my phone. So I might need somebody to tell me what shows up in there or.
Yeah, definitely.
Cool. And there will be a Q&A for other questions afterwards, as it was mentioned. I do want to specify that this is not going to be a forum to debate trans rights or whether they is a grammatically correct singular pronoun. I will have that conversation with you if you want. You can email me And I will talk about all of that, but that just takes too much time for this specific group. So the learning objectives for this presentation are that you will be able to define some terms related to trans support and identify some gender neutral language that is already regularly being used. You will be able to recognize different steps people take when they decide to transition and how these steps may affect milk production. You'll be able to apply inclusive language to your notation and intake forms if you use those. And you will be able to recall ways to make your clinic or workspace a more gender inclusive environment. And we will really be doing that in that order for the most part. I start with some terminology and definitions, and then some gender neutral words, some terms that are already gender neutral anyway that we don't necessarily think of as being gender neutral. And then I will show some examples for ways that you can modify your intake forms. And I do SOAP notes because those were the notes that I learned how to do in a clinic. If you don't know what SOAP notes are, I'll go over exactly what those are later. There are some other notation forms, but I'm not super comfortable with them and we're limited on time, I decided to stick with the SOAP notes. I will then talk about binding, top surgery, and testosterone injections and how each of those may affect people's ability or decision to lactate. And I will talk about ways that you can, things that you can do in your workspace so that it looks and feels more like a gender inclusive environment, if that is a choice that you decide to make. All right, so starting right off, I know that most people here probably know what most of these things are, but I just want to make sure that we're all on the same page. And just so everybody knows, I actually have a baby over here in the room with me, so there may be some baby noises, but she should be having a nap, so hopefully it won't be too noisy. First, trans or transgender is an adjective which describes a person who does not identify with the gender they were assigned at birth. And two things that I want to note. One is that it is an adjective and not a noun. A person is transgender. They are not a transgender. And this is very important. The only qualification for a person being trans is them saying that they're trans. There are things that people do to look and feel more masculine or feminine when they're trans, but they may also choose not to do those things, and those people are still trans. And then the opposite of trans, people who do identify with the gender they were assigned at birth, is cis or cisgender. And then the term AFAB, which is an acronym, AFAB, stands for assigned female at birth. There are, of course, also trans people who are AMAB, assigned male at birth, but that doesn't really come up in the context of this presentation. And then we have transmasculine, which is kind of combining the previous terms. A trans person who is AFAB is transmasculine. And again, this is regardless of whether they have any hormone treatments or surgery or anything. I will later be referring to top surgery, which is a surgery done to make chest tissue appear more masculine. Clinically, the procedure is a subcutaneous mastectomy, and then it may or may not involve the nipple and areola being removed and regrafted. And I'll talk more about this later. just wanted everybody to know what top surgery is. Non-binary, or NB, is a person who does not strictly identify as male or female. These are generally the people who are using they, them pronouns as a singular, but this is non-binary is a very broad term. Some people are unsure of their gender identity, so they decide to be non-binary until they, really figure things out. Some people just are not specifically male or female, just somewhere in the middle, so they are going to identify as non-binary. Some people are gender fluid. Some days they're a he, some days they're a she, some days they're a they. And then there are people who are agender, who don't identify specifically as any gender at all. And one other thing to note there is that NB, ENBY, it is, depending on who you're talking to, but I think generally speaking, it is acceptable to use that as a noun. A person might refer to themselves as an NB. And then we have gender dysphoria, or incongruence, I think is a term that's being used clinically now more, which is a specific type of body dysphoria where your body, the way your body looks doesn't match the way you feel. I feel like probably everybody is familiar with body dysphoria. Gender dysphoria is just a more specific version of that. And it's important here to know that what gender dysphoria is and how it can impact our patients. But treating gender dysphoria is, it's well outside my scope of practice as an IBCLC. It's definitely one of those things that you would want to refer out for if somebody is experiencing severe gender dysphoria. Okay, and then, some terms that are already gender neutral that we're using anyway. The first one is lactate. Anybody with a pituitary gland can lactate, and there are numerous conditions and medications that cause people to lactate spontaneously regardless of gender. And I think generally speaking, lactate is considered a non-gender specific term. Milk. I've heard people complain or talk about how the term, using the phrase breast or chest milk, sounds kind of clunky and affected, and that saying the phrase human milk sounds like weirdly clinical or alien. I've heard both of those. But if you're in a lactation clinic or something similar and you're talking about milk, the fact that it's human milk is kind of is generally implied. I think if somebody is talking about cow's milk or goat's milk, that would be specified. Whereas if you're just talking about milk, the assumption is that you're talking about human milk. And then also, just words like feeding and suckling are already, they don't necessarily apply to one gender or another. As well, the term parent, and then moving on from that, gestational parent, non-gestational parent, lactating parent, non-lactating parent. These are all words that were already used in the context of adoption and surrogacy and step families. So using them in the context of trans parents is just kind of a natural progression from my point of view. And then a lot of the words for the tools that we have in lactation clinics. we talk about and use breast pumps a lot, but how many different types of pumps do you have in a lactation clinic? They're pretty much all going to be breast pumps. And generally speaking, when you use it as a verb, when you're talking about pumping, you don't talk to a parent about how many times a day they're breast pumping. You talk about how many times a day they're pumping. So using it as a noun, might take a little bit of getting used to if you're not already doing it, but it can make, a lot of difference for some of your patients. And then the same with nipple shields. That's already a term. That's a gender neutral term. Anybody can use nipple shields. And then the SNS system, the supplemental nursing system, that is also commonly referred to an at-breast supplementer, which I would recommend if you're trying to be gender inclusive in your clinic to use the term SNS as opposed to ABS, the at-breast supplementer. But I feel like that's used more now anyway. I may be wrong, I don't know, but I feel like at-breast supplementer is I don't know, I think of it as like an old-timey phrase. And then the word they. If you ever don't know somebody's gender, it's always grammatically and socially correct to use the word they. If you find a wallet on the ground, you say, oh man, I hope they find it. So using it in terms of somebody who's you haven't met yet or whose pronouns you're not specifically aware of, again, it's one of those things that it might take a little while to get into the habit of doing it, but in the right place at the right time, it can make all the difference for some patients. And then regarding some anatomical terms, this quote is from a survey of trans men, which I have a citation to at the end from Garcia Acosta et al. And, while most of the anatomical terms do apply to everybody, nipple, areola, ducts, tissue, skin, chest wall, all get used during lactation consultations. The term breast, although technically everybody has breast tissue, culturally, the word breast is so associated with femininity that it does generate, a lot of discomfort among trans men and non-binary people. And I think that's, I feel like I hear people arguing the point that everybody has chest tissue, or everybody has breast tissue, but, culturally, it's just such a significant thing that I feel like it's important to remember that. Sorry, I just got a little went on a little rant there. Yes. Anyway, and that's actually a really good survey to read. Like I said, I provided the link at the end there, and there's a lot of good information in that one. I just picked this one quote. And then, but regarding other anatomy and people's genitals, if it doesn't come up a lot in lactation work, but for any doulas or midwives out there, it might. I would always start with asking somebody if they're comfortable using medical terminology for their genitals, or if they have preferred terminology. And again, it's not very often that that specific parts of the anatomy are going to come up in conversation. You might ask how somebody is, how somebody is feeling, but it's very rare that you're going to be asking a client or patient specifically about their vagina or their labia. So, you might just refer to it in a more general way. The exception, I feel like, is the perineum, which comes up in discussion a lot right after people have given birth. And it's important to remember that everybody has a perineum. That was actually going to title this webinar that, but I decided against it. And I want to draw attention here to the fact that I don't have a list of words to take out of your vocabulary. I feel like helping patients feel comfortable is what this is kind of all about. So if your patients prefer the term breastfeeding, use the term breastfeeding. We meet the patients where they're at. So, but which kind of leads into the next bit, which is how do you know ahead of time if somebody prefers the term breastfeeding or chest feeding? And of course, the answer to that is intake paperwork. And the suggestions that I make here regarding intake paperwork, I feel like most people already have preferred name and name as it appears, on your ID or your insurance, something like that. But I think one of the things that's really important here is that you put preferred name first. And maybe even, now that I look at it, take off the word preferred and just have name. Because for a lot of trans people who have changed their name, that's a very big deal, even if they haven't legally changed their name. But it's part of the taking on your new or true identity. So I would definitely have that first, and then something like name as it appears on insurance. Like, if that's not the same, we just need that for paperwork. But what is your name is most important. And then for pronouns and terminology things, I would definitely have it being a circling thing as opposed to a fill in the blank, because and I'm speaking from the point of view of a lactation clinic, is we have people who maybe haven't slept in a day or two with a baby who's not eating very well. We want to keep those intakes as easy and concise as possible. So, you may not remember right off the bat what's a pronoun. So just circle she, he, they, and then definitely have an other for people who use pronouns other than those. But when you start listing all of the alternative pronouns that some people use, I feel like you move away from it being easy and concise. And then the same with terminology. You don't want to make people guess what you mean when you say, I prefer the term blank. Give a list of options, 2 or 3, maybe 4 options, and then an other if they have a different set of terminology that they prefer. And then if you do, take somebody's name and pronouns and accidentally use the wrong one, it's really important that you don't make a big deal out of it, because then you're kind of moving away from gender affirming care. Then you're, maybe putting that person in a position of having to teach you or having to make you feel better about something you did, as opposed to, you helping them. And especially if this is a clinical situation where you're being paid, like, you don't want to, take up too much time with your feelings. So I just want to, and again, this is from, I have the link to this this is from the a protocol from the Academy of Breastfeeding Medicine on LGBT patients. So I just want to read out here. It's best the mistake be acknowledged so the individual feels respected, but prolonged attention to the mistake may take focus away from providing appropriate and affirming health care. Don't make a big deal out of it. Correct yourself. Move on. And so moving on, I want to talk about SOAP notes. And notes are SOAP notes. It's an acronym, of course: subjective, objective, assessment, and plan. And what I'm going to do with this is I was given a set of SOAP notes from a clinician friend of mine. And, she redacted all of the pertinent information and everything. But I just took a few bits out of it for just like a general consultation and came up with ways to modify them so as to so it could apply for a non-binary patient or a patient of any gender. So I want to go through the S and the O, and then for assessment and plan, I've put the originals, and then I would like some people in the chat box to talk about ways that we can modify the assessment and plan notes to be more gender inclusive. So for the subjective, which is what the patient reports, patient reports concerns with latch, reports initial latch in hospital was fine, but seems to have gotten worse due to maternal nipple soreness. There, I took out the word maternal because the nipple soreness, it's implied whose nipples are sore. Mother reports she has difficulty breaking latch when it's shallow, to attempt a deeper latch as infant's suck is strong, only feeding on one breast, at most feeds as infant falls asleep. And you can see I just changed the word mother with parent and breast with side, and the meaning of the note remains the same, but it could be applied to a parent of any gender. And again, I'm not saying you should start doing this with all of your notes, but these are just ways that you can take notes for a patient regardless of their gender. And then moving on to objective, which is what the clinician observes. Breast appearance: round, well-developed, closely spaced and symmetrical, protractile nipples, and pliable areolar tissue. Breast tissue bilateral, firm nipples right, left not viewed today, stage 2 nipple damage. And here you can see for this one, I just feel like if you replace the word breast with chest, or just take it out entirely and just start with appearance, then based on what is being described, it still makes sense. So if we move down to assessment, patient is lactating adult female, adjusting well to mothering this infant. Milk supply is adequate for this stage postpartum. Engorgement is occurring as infant is not fully draining breasts. 50% of visits spent in education and counseling, RE general breastfeeding management. So what are some ways that we could make this apply to a patient of any gender? And again, I can't see the chat box, so
I can see it. Uh-oh. Oops.
Oh, there we go.
Okay. Okay. Well, Jacob, I don't know. You could just continue. Yeah.
Okay. Can, in fact, nobody see the chat box?
That's all. They can see. It's okay.
Okay, that's it. So on this one, I feel like we have a really good opportunity.
We can't see the chat box.
Oh.
Okay.
Okay. Um.
I can just
mm,
continue.
You sure?
Yeah.
Okay.
Okay. So on assessment, I feel like we have a really good opportunity to use the word AFAB. Patient is lactating adult, assigned female at birth. And then we could say adjusting well to parenting this infant. Engorgement is occurring as infant is not fully, we could say something like removing milk. And then 50% of visit spent in education, RE, general lactation management. And again, that everything there still means the same thing. We haven't changed the meaning of the note at all. And then with plan, plan actually does not have a lot to change. Being that this is a lactation clinic, there's a plan for the parent and a plan for the baby. So you could definitely say parent instead of mom, easy enough. And then you might say pump both sides every 2 to 3 hours for 15 to 20 minutes, or double pump. But yeah, everything else is really, really good at applying to people of either gender. So for the next part, I want to talk about things that people do to appear and feel more masculine. The first of which is binding. And I've got the picture citation under the pictures for these. So for those who are unaware, a binder is an undergarment used to flatten the chest and give a more masculine appearance. And generally speaking, binding is an incredibly safe and healthy thing to do. Even if your body is still developing, there are binders specifically made for those people, for younger people. It can be problematic during lactation. You can, be uncomfortable, certainly, but can lead to clogged ducts, which, can lead to mastitis, engorgement, possibly abscesses, all of those things that come along with severely clogged ducts, if somebody decides that they do just want to, power through the discomfort. But one thing I want to note here is that finding out you can't comfortably bind may cause patients to decide to stop lactating. And some people may view that as a cosmetic thing, and some people may view it as a mental health decision. And I feel like as a clinician, you need to decide how you're going to feel about that. Are you willing to help people cease lactation because they can't wear a binder anymore, or because they can't comfortably wear a binder anymore? Or is that something that you want to refer out to, and then who will you refer out to? I feel like you, and I'll talk more about this later, but having a list of people you're willing to refer out to if there are certain things you're not comfortable with is very important. And then next, we have top surgery, which I referred to earlier. In this picture, you can see the nipples have been, the nipples and areola have been removed and regrafted. And the way that it affects lactation depends on a lot of things. First and foremost, whether the parent decided ahead of time they wanted to have a child. So some people have top surgery knowing that, you know, when they get older, they might want to give birth and nurse their child. And in that case, a doctor can avoid removing ductal tissue and just remove adipose tissue, or avoid removing and regrafting the nipple and areola, because those things can both lead to more problems when you're lactating. Otherwise, you know, it's not terribly different from a reduction mammoplasty. I mean, it is different, but as far as how it physically affects the body. And while milk ducts are incredibly good at healing themselves and reattaching, if somebody has had ductal tissue removed, you know, for any reason, clogged ducts are going to be more common and more to be expected. So that's something you would definitely want to talk to your patients about. Okay, and then moving on to hormone treatments. Which is, you know, just injections of testosterone to encourage a more masculine appearance. And, you know, muscle tone, voice deepening, that sort of thing. And testosterone is generally contraindicated for lactation because, and this is very important, because testosterone inhibits lactation. So if you want to start taking testosterone again, it will decrease the amount of milk you're producing, but testosterone does not affect milk quality. And we know this for three reasons. One, cis women produce testosterone anyway. Everybody produces testosterone in varying degrees. Two, testosterone, not much testosterone ends up in the milk supply. They've done tests on, you know, milk from people with different testosterone levels, and there's never much testosterone in the milk to begin with. And C, testosterone has really low bioavailability. So even testosterone that does end up in the milk that the baby consumes doesn't get absorbed by the baby very well, which is why testosterone is injections and not pills. Your stomach doesn't absorb it very well. So taking testosterone, you wouldn't be able to exclusively chest feed your child, you know, most likely. But it's not a one or the other thing. A patient, if they felt like for their mental health they needed to start taking testosterone again, but they really wanted to nurse their child, it's not a one or the other deal. It's just a question of how much milk they're creating. Now, that being said, if somebody did want to stop lactating, then taking testosterone, especially if they had previously been taking it and want to, you know, get back on testosterone, it's a good way. It's a great way to stop lactating if that is what you want. And again, I've got the citations for all these at the end of on the last slide there. So, if you do decide, if you do want to encourage gender inclusivity in your clinic, so what are some ways that you can do that in the like the actual physical clinical space? One, I would say, well, and sorry, I'm actually going to do these a little bit out of order. Have pictures of trans people, of pregnant trans men and nursing trans women in your clinic. I feel like we see a lot of racial and ethnic diversity in pictures on people's clinic walls. And that's great. And I'm not saying we should have less of that, but to include other types of diversity as well. And really even having pictures of cis men holding babies. I mean, we love babies too. Update your referral list. If you do feel like you are not super comfortable taking care of trans and non-binary patients, I feel like the least you can do is to know who is, and that is a good source. If you're an IBCLC and you're not comfortable having patients who identify as men, know which IBCLCs are. And then also have therapists for people who are having gender dysphoria, if that's not in your scope of practice, and as well endocrinologists who treat trans and gender non-conforming patients, because if you just give somebody a list of endocrinologists, some of them will be, but some of them will not. I've heard that within the endocrinology communities, there are people who are adamantly, they do not do that. And, you don't want to give that phone number to a trans man who, wants to start taking testosterone again, or for the first time. Normalize using gender neutral language among people whose gender you don't know. If you haven't seen their intake and you haven't met them yet, be in the habit of referring to people as they, and using your own pronouns when you introduce yourself, so that if there's somebody whose pronouns you don't know, you're already in the habit of having that conversation. You're not just assuming people's pronouns. And learn more about these issues. Two books that always come highly recommended are Thomas Beatty, Labor of Love. Thomas Beatty was and I want to make sure I say this right, he was the first American, and I want to say the first person in the world to be legally recognized as a man and to give birth to a child. This was in 2004. And full disclosure, I have not read Labor of Love specifically. I've read some other stuff. But it's a memoir, as is Trevor McDonald's Where's the Mother, which I have read, which is a really excellent book about Trevor chest feeding his children. Well, one baby specifically, and then the other baby is born later on in the book. Anyway, and these are both memoirs. They're not clinical books, but they are, I feel like, really good starting places for people wanting to learn more about the subject. For clinical book, I would recommend Trans Bodies, Trans Selves, which I believe is coming out with the second edition soon. But anyway, yeah. So to review, we've gone over some terminology, some which may be new, may not be new, as well as gender inclusive language, which may be used in new ways. We've gone over steps transmasculine people take to transition, including top surgery and or testosterone. And again, even if people don't do these, they're still trans. If somebody tells you they're trans, that is end of conversation. They're trans, or not necessarily end of conversation, but there's no debate there. We've talked about gender inclusive note taking and intake forms and other things you can do in your professional environment to prepare for the possibility of having trans or non-binary patients. And so there was talk of a Q&A, but given the technical problems, is that still possible?
I think it should be possible. Maybe we can have them have the attendees raise their hand and take themselves off of mute and ask their questions that way. So I'm opening up. That was an awesome presentation, Jacob, very informative.
Good. Thank you so much. Thank you so much. And yeah, and do the slides go out to the attendees?
Yes, they do. They do.
Okay. Cool.
So let me see here. Oh, somebody does have questions. Cool. Oh, awesome. Okay. Oh, wow. The chat was right here. Okay. So, let's see. Okay, so someone just said, can you show the slide? Okay, I did that. Does anyone have any questions? Oh, wow, they were, Jacob, okay. Okay. Does anyone else have any other questions? Now that we see the chat box, you all can ask questions here now that we can see them. If anyone has any questions. Someone asked Jacob, where can we get the resources?
Sorry, which specific resources?
Yeah, which specific resources? Let's see. What did I just do? Do you have any good resources for finding images of pregnant or lactating trans folks?
So the images that I used all came from Flickr.
Okay.
Which has the people who post images there, it says under the bottom if they're Creative Commons or which if they're all rights reserved or what have you. So yeah, that's where all my images came from. Although also things like Shutterstock had a few.
I was going to say.
So I stock photo websites that and then just check the licensing.
Okay. We have another question here. What professional do we refer to for induced lactation?
Which professionals?
Yeah, what professional do we refer to for induced lactation?
So, locally, I would say well, me, or but also I worked at Breastfeed Atlanta, and I know the owner there, Christy, has worked with that before. And then also there is a woman named Alyssa Schnell she has an organization called Sweet Pea Breastfeeding. She wrote the book Breastfeeding Without Birthing, which is all about induced lactation, and she does telehealth, and she has webinars for both professionals and I think for people who are interested in inducing themselves. She's a really great resource for induced lactation. I mean, she literally wrote the book on it. But as far as like consultations with somebody locally, my contact information is on the final slides. And then also Christy Corsi at Breastfeed Atlanta.
Okay, we had another question. Oh no, I think I lost it. Oh no, I did. Well, let's see. It was Jacob, someone had said that they would love to add you to the referral list. To their referral list, so that would be awesome.
Yeah, absolutely.
If I could find the question. Okay. Okay. I don't know what happened. I don't know what happened. Sorry, everyone. I was seeing questions at first. Now I don't see them anymore. Let's see here. Oh, here we go. Adjusting well to peritoneus. Sorry, Jacob. I'm trying to pull back the question that I saw. Someone asked, how does the word nursing rate for I can never say this word, inclusiveness?
Sorry, what was the question?
How does the word nursing rate for inclusiveness?
So hold on one second.
Okay.
Yeah, but we're finishing up. Okay, sorry. I actually have to go after this question.
Okay,
but,
no problem.
So yeah, I think it's one of those things where, generally speaking, I think it's kind of assumed that some people, particularly transmasculine people, might feel uncomfortable from the term, and that from that quote that I provided earlier. But it's one of those things where if you have it on your intake, then problem solved. Then everybody, then you immediately know how your patient feels about that.
Okay. Well, that's the end of this webinar. Thank you so much, Jacob, for your flexibility and being so understanding. We definitely appreciate it. A few final notes. A follow-up email will be sent out after this with a copy of the slides, the recording, and feedback survey. The survey will close next Wednesday, so if you are applying for CE credits, please be sure to fill out the survey and we will provide CE credits afterwards. But fortunately, just now thinking about it, unfortunately, we will not be able to provide CE credits for this webinar, but the next one we're having, we will be providing CE credits. But thank you all so much for attending. And thank you so much, Jacob. We really, really appreciate it. And it was an awesome presentation.